Hi, this is Dr. Tony Daher speaking, and on behalf of the GDIA and myself as the co-director of the GDIA, I'd like to welcome you to this webinar. The topic of this webinar will be, as you see from your screen, predictable mandibular 2 implant overdentures, and we're gonna present to you some clinical tips. Hopefully you will be able to use it in your private practice. Okay, regarding CE, we have to let you know that you must remain active in the webinar for the entire time to receive your CE certificate. Once the webinar ends, a pop-up window of the evaluation will appear on your screen. You will also receive an email in case you did not see the pop-up. Also, from continuing education requirements, I have to let you know that I have no financial affiliation, and I declare that neither I nor any member of my family have a financial arrangement with any corporate organization offering financial support or grant monies in regards to my continuing dental education presentation for this GDIA webinar. And certainly you will have 1 hour of CE after we're done. So the objective of this webinar is mostly gonna be talking about the principles behind a successful treatment regarding the mandibular 2 implant overdentures. And also we'll be covering some concepts of the mandibular 2 implant prostheses. And as I said, some practical clinical tips we'll be covering during that webinar. As you know, the denture wearers' complaints are divided, can be divided. Either the patients complain about that prosthesis is ugly, or it's uncomfortable, or it can be ugly uncomfortable. And you see sometimes that patients comes into your practice with a brown bag, opens a brown bag and start complaining about, oh, I love that denture teeth, I like that denture, but the setup of the teeth that I don't like. That denture, I like the setup, but I don't like the fit, and so on and so on. So what do you do with these kind of patients? What type of treatment available to meet their chief complaints? One way is this way.
Hi, how are you?
Just fine.
What seems the problem?
I'm having problems with my teeth. They just don't fit anymore. They're causing me pain. They're causing sore spots in my mouth.
Can you describe the problem that you have?
It's been over 2 years now, and they're still bothering me. They're real loose, and they're causing me to have wrinkles here. I've got sore places in my mouth. They lift up, they fall out of my mouth. And I have wrinkles here and here, and I've been here about 5 different times. I'm fed up.
Bye. Bye.
Certainly, this is one way, but another way, then let's talk about it. We know for a fact that ugly dentures can be made pleasing, and you can see from this picture here, this is before and this is after. And certainly you have to familiarize yourself with some aesthetic guidelines that Dr. Fresh long time ago talked about it in the 60s. So denture setup, teeth setup, and also the fit and so on. I will show you how to make a comfortable dentures. Dr. Burns in 1995 told us that successful complete dentures are retentive and stable, and you know, I'm sure you know about that. On the other hand, Redford surveyed denture wearers and found out that 50% of these denture wearers, they have problem with their mandibular complete dentures, and it's mostly in relation to lack of retention and lack of stability. Are there any treatments available to enhance the retention and stability of these complete dentures? Yes, absolutely. You know, everybody knows nowadays treatment with dental implants shifted from a peripheral to a central position and become really a part of our daily private practice. Mandibular overdenture treatment modalities, it all depends, the modality depends on the number of implants you're going to be placing. Now, if you place only 2, it doesn't matter if you connect them or not, then the prosthesis over that has to follow, we have to apply basic biomechanic principles. So the prosthesis is going to be mostly tissue supported and implant retained. On the other hand, if you place more than 2 and you spread them as far apart as possible, then the prosthesis is going to be like an implant supported and also implant retained. And it's going to feel like a fixed bridge, but it's removable by the patients. So biomechanic is very important, and because of this biomechanic, your treatment sequence and your protocol is going to depend on the type of prosthesis that you're going to be doing. Indication of when do we do implant mandibular overdentures? As I said, when you want to improve the retention and stability of these, especially the mandibular complete denture. And certainly in patients with xerostomia, we know for a fact that saliva is very important for that suction, and also minimize the rubbing effect of the denture bases with the soft tissue. And certainly in partial loss of the mandible in case of an accident or cancer. Now, as I said, by placing couple implants, you're going to improve the retention and stability of the mandibular denture. So I want to share this situation with you guys. So patient's been wearing denture for so many years, went to her dentist to get the new sets, and then her dentist said, you know, I can improve the problem with your mandibular denture. Let's place 2 implants and your problem will be solved. So 2 implants were placed in the anterior portion of the mandible, and patients went home and then came back 1 week later, and she started complaining. She said, well, you know, I spend money and get these 2 implants, but my mandibular denture is still feel the same as my old one. It's not retentive, it's loose. So what seemed the problem? And when you look at that mandibular denture that the previous dentist did, certainly there is a problem with the anatomy of the flanges and so on. We know for a fact that you have to cover certain primary support areas. And if you remember your dental schools and so on, the primary support area is mostly related to retomolar pad, and it's not a resorbable area. So, and the reason why it's not resorbable because it's the attachment of 4 different muscles. So we have to cover that area, so give some support in the posterior ridge areas. Also buccal shelf. Buccal shelf is made of compact bone. It does not resorb under pressure. When you contrast it with alveolar bone, now certainly alveolar bone, when the teeth are extracted and under pressure, the alveolar bone is going to disappear. And this is when you look at these flanges, and certainly there's a problem. Either the anterior lingual flange is overextended, or the posterior lingual distal flange is underextended. But look at the occlusal anatomy of the occlusal surfaces of the premolar and molar. We know for a fact that the buccal cusp of the molars and the premolar are higher on the plane of occlusion than the lingual. So now we're talking about the different, it's an inverted type of an occlusal scheme. So now let's troubleshoot it. So the patient was referred to my office, so I had to troubleshoot it to see what's the problem. So the first thing I'm going to do is I'm going to take that denture and try to snap it over these ball attachment. And you have some retention given by these ball abutments. Now, certainly one is not very adequate because of the cuff height, is inadequate cuff height, but retention exists. So now I'm going to ask the patient to put the tongue on the roof of the mouth, move it back slowly while closing. And I'm going to ask the patient to, once the teeth start in contact to stop. So she did that, and when you look at your slide on the left side, the teeth start to be in contact, but not on the right side. Then I told her to squeeze, and suddenly the lower denture lift up from the attachment and start hitting the opposing. So what you see here is mostly problem, not only the design of the flanges and the type of occlusal surfaces, but also problem with occlusion. So that occlusion is not balanced. So in a way, 2 implants gonna improve the situations if you respect basic removable prosthodontics principles. So it's very important. And this is, for example, an example of a well-made complete dentures. So bottom line, in summary, 2 implant cannot help badly made denture. But on the other hand, 2 implants will improve a well-made denture. So designing is successful. It doesn't matter if you put a prosthesis over 2 implant or on 3 or 4, 5, 6, and 7. That prosthesis you're going to be designing should start with a successful all on none prosthesis. And that prosthesis has to be functionally acceptable, not only from an aesthetic perspective, but also from a functional perspective. So occlusion becomes a big factor in the stability of these dentures. So I want to show you 2 different videos here. The one on your right, on the left side, is the existing denture. And I want to show you that type of occlusion that that patient has. And you see the teeth are set up in a class 1 skeletal. And this is most of the lab technician will do that for you without, this is the norm in when you see in a lot of dental labs. So let me show you that video.
Go ahead, move forward. Move forward. A bit more. And put your chin down. Chin down. Okay. Now, go ahead, move forward. Back. Right. Move forward. Back. Move forward.
And you hear that sound,
Back.
the suction is broken.
Move to the side. Back. Move to the side. Back. And move to the side. Okay. That's it.
So now I'm going to show you the same patients. I made a new sets of denture for her. Now, the interesting is if you retract the lips and retract the cheeks, what's going to happen? You ask patient to move left and right, and if the occlusion is balanced, then the mandibular denture or the maxillary denture will not move. They stay put.
Back. Side. Back. Okay. Now slowly grind left like an arm. Okay, hold it. Very good. Sit. Now bite all the way in the back. Chin down. And move the teeth over like this. And like that. Okay. And here on the top. Smile. Very good. Very good.
So we have to agree on what type of an optimum occlusal concept. And this occlusal concept is universally accepted. And you have to have a maximal intercuspation in centric. And certainly when the patients move left and right, you don't want to have you don't want to have any deflective occlusal contacts in excursives. And certainly you have to have some kind of available cusps for selective occlusal reshaping. And remember that you're dealing with acrylic. Acrylic, when you bake it, is gonna shrink a little bit. So you have to do a little bit of selective occlusal adjustment during the placement of these dentures in the patient's mouth. And certainly in the end, they have to have a good natural and pleasing appearance for the tooth arrangement that you are creating. Now, there are two different type of occlusal scheme accepted to get that stability during fabrication of complete dentures. We refer to it as a bilateral balanced denture occlusion or lingualized, and it's mostly when the patients move left and right, you have contact on the working side, and also you have contact on the non-working side. It's mostly to have a tripod effect and keep the dentures always glued to the soft tissue of the patients. And certainly that balance occlusion will minimize the tipping on these dentures. Another type of occlusal scheme, this is what I like when no implant are involved, is what we refer to it as a non-interceptive or linear occlusion. And slang terminology is autocentric type of an occlusion. When you look at it, look at the maxillary posterior teeth. The premolar and molar are set on the flat occlusal plane. So the type of teeth are not three-dimensional like the one before. On the other hand, on the mandibular arch, the premolar and the molar, their functional cusp tip are turned into a blade, very sharp. And these teeth are made of porcelain. So you have a bladed teeth on the bottom against the flat occlusal surfaces on the maxillary arch. But also I want you to see the vertical overlap of the anterior teeth. There is no vertical overlap. So when the patients move forward, like on the middle slide here, when the patients move forward, you always have contact in the back and barely the front teeth touch together. And this will give you a very good stability for your prosthesis. And let me show you a video with that type of occlusal scheme. Slide, tap, tap, and slide all around, all around. Keep your teeth together and slide all around and forward, forward, back and forth, slide all around. Very good. Left, right, slide forward, left, back and forth, left, right, all around now, all around. Okay, very good. Now open wide, open here, open and smile. You need to smile.
I am bloody smiling.
You want to show me some teeth.
Okay.
Turn your head towards me and smile. Okay, now go ahead, say Mississippi.
Mississippi.
55.
55.
Mississippi.
Mississippi.
Very fine.
Very fine.
Mississippi.
Mississippi.
1666.
1666. Mississippi.
55.
55.
1666.
1666.
Very fine. Okay,
Very.
Relax your lip. Stay like this and relax. Very good. Relax your lip. Okay. Relax your lip. Very good. That's what we want to see. And you see even this type of occlusal scheme, but if you follow basic aesthetic guidelines, when the patient is talking and smiling and so on, you don't see that flat occlusal surface of the upper teeth, and you don't see these blades. Now, I'm sure they had that question that every time I show that video, somebody would ask me, what about that click, that when the patient's biting down and you hear that sound? If you tap your teeth together and you have natural teeth, and certainly you're going to hear some clicks. Now, if the patient's eating, you're not supposed to hear any clicks, and the patient also will not hear any clicks. If the vertical dimension of occlusion is excessive, then when the patient is eating, you're gonna hear some clicks. So bottom line is that sound will give you an idea if your vertical dimension of occlusion is correct during speaking and also during chewing. Another clinic situation, this is one of the peer review that I had to be an examiner. And the question I have for you, which one do you think it's correct and which one is not correct? I'm sure you agree with me, everything went wrong here. Lip support, very bad. Not only the mandibular lip support, but also the maxillary lip support is very bad. Selection of these abutment, locator abutments, very high cuff heights, position of these implant, the shape and the state of the soft tissue on the mandibular arch, the exostosis and all the stuff, the type of occlusion and so on. So a patient had to sue the previous dentist and she got a lot of money. Now the question I have for you, at what inclination do we place implant? If you look at that mandible here and the cross section on the right side, now certainly you agree with me that an implant will be placed between the two cortical plates, and this is a good inclination, and you want to keep the platform of the implant at the top of the bone or 1 millimeter below. But at the same time, sometimes you can do it in that angulation or in that angulation, and all the three different angulations we are keeping the platform of the implant at the top of the ridge and between between cortical plates here. So you have to make sure that we get the right directions, the right angulation. So when you look at that before and after dentures here, and if you want to place an implant according to the old mandibular denture, then the angulation is going to be this way and be situated between the two flanges of that denture. But with the new denture, when you want to restore the vertical dimension of occlusion and get a good lip support and so on, so that angulation of the implant is going to be a little bit different. So it's very important before you place an implant, then you have to do a nice, predictable pre-surgical denture. And because of that, we start having, Jack, my lab technician, and myself, we decided to set up a 2-day course on how to teach dentists to make acceptable, predictable, complete dentures. And and we have an institute in Sacramento, and it's a 2-day course on live patients. And then we show you how to make a nice impressions, final cast, ECB, aesthetic control bases, mean wax rims, and tracers. Okay. And then that denture, the pre-surgical denture, we're gonna duplicate it and turn it into a radiographic template. And that radiographic template also is gonna be turned into a surgical template. And according to that, you make your diagnosis and you get a predictable result. For us, a CBCT radiographs are a good diagnostic tool if I can see the silhouette of the final destination. Certainly, if you don't see that, you can see the silhouette of the bone. But how are you going to place that implant according to what inclination, it all depends on that final destination. And sometimes if you look at the middle slide, sometimes you might have to do bone grafting to idealize the position of these implants. Another thing is a bunch of prosthodontists met in Montreal, Canada at the McGill University in 2002, and they came out with a statement on overdentures. And let's read it together. The evidence currently available suggests that the restoration of the edentulous mandible with a conventional denture is no longer the most appropriate first choice prosthodontic treatment. There is now overwhelming evidence that a 2-implant overdenture should become the first choice of treatment for the edentulous mandible. It means what? It means if a completely edentulous patient comes to your practice and wants new sets of denture, the first choice of treatment for this patient is you have to tell him about the 2-implant and the mandibular overdenture, over 2-implant, and an upper complete dentures. Now think about it. If it was your mouth and you have the money, you have the time to fix your mouth, what is your first choice? What would you like the dentist to tell you about the first choice? Certainly it's going to be a fixed bridge. And then if you have money and you have time, certainly making a fixed bridge will be my first choice. And then afterwards, depending if the patient has money or he has not enough or has the time to do all this, now you can degrade the treatment to implant, to 3-implant, and so on and so on. So the first choice for me is a bridge, not a 2-implant mandibular overdenture. So I don't like that statement. And now we're looking at it very closely. A vertical requirement. This is another big factor that we see a problem in private practice. Remember that sometimes you're dealing with patients did not have enough time to get accelerated bone resorption. And then say, oh, he has a lot of bone, let's place a couple implants. And then afterwards you have to put an abutment and you have to put a housing. And then because of that vertical dimensional occlusion is very minimal, so you end up with acrylic over the housing, very thin. And then afterwards the denture is going to break. And Dr. Goodacre in his retrospective study told us that if this is not well respected, you're going to be dealing with at least 30% chances that the denture is going to break at this attachment location. So you need, if you're going to do a solitary anchor, you need at least 12 millimeter of interarch space. Bar or hybrids, you need more than 15 millimeter. How can you tell? It's mostly, as I said, when you're doing that pre-surgical denture, you can do all the measurement that you want, and you can familiarize yourself with how much interarch space is available to do. How do you attach mandibular denture when using attachments? And when you look at a lot of instruction manual, they tell you 2 ways, either directly in the mouth or indirectly in the lab. Studies showing that when you do it indirectly in the lab and when you design a tissue-supported implant retained prosthesis, when you get that denture from the lab, the only thing is going to be touching the inside of that denture is your implant, and you're going to have slight space between the integular surface of the denture and the posterior ridges. So the best way is to do it in the mouth. Now, let me show you these slides here. I got that denture from the lab. I made the holes a little bit bigger so the implant or the healing abutment here do not touch. And then I pipped the denture. And you see on the slides on the top, let me see if I can do it here. I can. Anyway, on the slide on the top, you see a very tiny area is touching the soft tissue. But I did the PIP. I took an acrylic burr. I removed this area until I have maximum contact between the soft tissue and the integular surface of the denture. So now what we're doing is making sure that we have maximum support area over these ridges. Okay, and we're doing an implant supported tissue supported prosthesis. And then afterwards, certainly we correct the occlusion. And I usually in the same visit when I place these denture, I do not attach the denture to the implant because I want the patients to wear it for a while and I want to see if it's going to have a lot of sore spot or not. If patient is going to have sore spot after 24 or 48 hours, I'm going to have to do troubleshoot. Either is the pressure, localized pressure, I adjust the inside of the denture, or if there is a wide area, then you have to look at the occlusion and correct your occlusion. And then when everything is acceptable in acceptable range, then we're going to connect the denture to the implant. And usually it takes me 2 to 3 weeks, and then I'm going to replace the healing abutment with locators. So the benefit of this technique, we're applying basic prosthodontic principle, better relation to the attachment to the tissue, and better retention and stability, and certainly is going to minimize the wear on the attachment, and you're going to deal with less frequent replacement. If you have to replace the retentive clip every month or every 2 or 3 months, now certainly there is a problem with the biomechanic of that denture. It means that the denture is not, the occlusion is not very stable, so there is a tendency of the lower denture to move, and these retentive clips gonna keep it stable, and then they're gonna overwork, and then it's gonna wear down and it's gonna lose the retention. Another thing I forgot to mention to you when I showed you that video of that autocentric type of occlusion. Somebody asked me and said, well, if you get this nice retention or stability of that denture, why do we need implants? Now, remember that when I talk about the two different terms, retention, and the other term is stability, it means two different things. Stability is against lateral forces. Retention is against dislodgement or moving the denture away from the soft tissue. So stability is mostly when a patient is gonna chew left and right and so on, but you want the prosthesis to stay put when the patient is eating some sticky food. Remember, a sticky food, patient biting on it, open the jaw, the food is gonna grab the denture, and by opening their jaw is gonna lift up the prosthesis. This is the time this implant is gonna help to retain the denture in place. So that patient I showed you without implant certainly should be able to eat most of the food, but she's gonna be away from sticky food. To be able to eat anything they want, now certainly you have to improve the retention on these dentures. I hope it's clear for you guys. Let's talk about the popular attachment for this kind of prosthesis. Locator is a very popular attachment, and if you ask a lot of dentists, this is what they mostly are familiar with. Dentists, they have different names. It's the same shape, the same size, and the name is kerator. And these kerator abutments, they come in a different cuff height or collar heights. And certainly you have to measure with the perioprobe where your platform of the implant situated according to the highest portion of the gingiva. And if it is 3 or 4 millimeter, then you're gonna prescribe, or you can buy a 4 millimeter collar height. If it's 3, then it's 3 millimeter of cuff height. And it's one piece and does not engage any internal connection. And you have a tripod drive feature is mostly to be able to, with a special driver, you can torque that abutment to a value of 20, at the most 25 Newton centimeter. The nice thing why it's popular, because it has a dual retention. If you look at this clear retentive clip, you have two features. The one, a plunger inside, and is going to engage into the internal retention feature of that abutment, and the outside, it's mostly is going to engage in an undercut of the outside portion of that abutment. So the combination of inside and outside the retention will give you a long-lasting retention life, as we say. And this is what, when you buy the Kerator, you have to buy that tool also. The Kerator 2-in-1 tool. One extremity, one tip is mostly used to remove. There is some kind of a lip to it. It's going to be removing the clip when you want to change it and if you want to replace it. And the other end, the one on the right side, it's mostly is going to help you to insert a new retentive clip into its respective housing. And also you have to buy that driver, a special driver. It fits inside this tripod tri-lobe effect. And certainly you have to have a torque driver to be able to get it into place with a 20 Newton centimeter. And the nice thing about it, if you have a problem with angulation up to 20 degree of divergence, then locator is fine. Now, if it's have more than 20 degree, like up to 40, then you have to use that extended range clips. The extended range clip, if you notice on toward your right side, there is no plunger inside it. So you have only one type of retention, it's outside retention. Show that video here. That video is a surgical video, but if you want to look at it from beginning all the way to the end, you can find it in our GDIA website. But the reason why I place it here, so with that surgical template, I usually ask my surgeon, when he places the implant or she places the implant, before to close everything down, I want to put a couple marks where the implants are. And this is going to help me during that second stage surgery. So that surgical template, mostly it's helping to place this implant according to certain angulation. And also it's going to mark it. So in case the surgeon is going to close the flap all the way down, and I want to see the patient later on for the second surgery, I don't have to do a big flap to be able to do it. So this is a video showing how to expose the two dentist implant using that surgical template. So you see, very tiny incision according to location to these marks. And you can go ahead and remove your cover screws and replace it with healing abutments. So now you gotta prepare the denture so it's gonna fit over this healing abutment, but it has to be in intended contact with the soft tissue. So I use some kind of a bite PVS, like Futar D here, for example. I need to mark where are the location of these two healing abutments. If you're gonna burr this area with an acrylic burr and keeping the PVS over the denture, it's gonna be a mess. So the best way is to mark where the location of these abutments on your inside the denture, on the integral surface of the denture. So select some carbide burrs, the same, a little bit wider than your healing abutments. It can be a round carbide burr or an inverted pear shape. And certainly, as I said, you have to get back that intimate contact between the integral surface of the denture and the soft tissue. So I want to show you how I attach the denture to two locator abutments. So you have a metal housing with a black plastic insert, and then you have the three different retentive clips. And this is the 3-in-1 locator tool. It's if you want to, this is an old one now. The locator company, they come out with a little bit nicer 3-in-1 tool. I will show it to you with the next video. And this is the gold one, is your driver.
That's the foliage. Zoom in now. Go ahead.
Usually you have to wait at least 2 weeks when you expose this implant for the healing abutment. You want to make sure that gum is completely matured and completely healed before you select the cuff height of these abutments. So this is a nylon, the white nylon ring. We don't want the acrylic to touch that soft tissue around your abutments. I'm going to show you two different ways of connecting the denture to the implant. I always do one at a time. You don't want to lock it in place. So I'm going to use some BCMA, taking a round burr, make undercuts, put some bonding liquid. And this type of BCMA does not bond chemically to the acrylic of the denture. So you have to have undercuts. Always we want to have an escape hole for the excess of that BCMA material. Ask the patient to go back and center it. And then you see it's very easy to remove the excess. As I said, BCMA will not bond chemically to the acrylic. So it's very important to make undercut inside this hole with the round burr and use some bonding liquid. So second way, if you want, you can do with cold cured tooth-colored acrylic. You look at my finger and the escape hole. My finger is closing that escape hole. I use monomer first and then saturated with the powder. Why tooth-colored acrylic? Because I can see where the excess acrylic afterwards, so I can trim it. So you evaporate the excess monomer a little bit. And if you notice here, we did not put any, we forgot to put that white nylon ring, but we can catch up the mistake by relieving the area around the gum area around the abutment.
And hold it. Okay.
So now it's very easy to remove the excess by looking where that tooth-colored acrylic is.
Okay.
And we're gonna I guess the video is a bit loud, so with that end, we're gonna remove that lab clip, and we're gonna replace it with a retentive clip. Usually the blue is the least retentive, the pink is the medium retention, and the clear is the highest retention. The experience in my practice tells me that usually male patients like the pink retention, the medium retention, and the female patients mostly happy with the blue retention. Should be the other way. Pink is for female and blue for male, but it works the other way around. Certainly, the less retention, the better it is. You don't want to over torque the implant, and also if the denture is not well made, that clip is going to overwork and you're going to lose retention very fast. And before you dismiss the patient, certainly you have to show him how to place it in and take it out. I usually ask him to do it 5 times. And we go over oral hygiene. Has to clean the denture and clean the abutments and clean the soft tissue and clean their tongue.
That's mine. Okay, Mom, you want a joke? I'll put it in. Say it's fine.
Now, certainly you end up, sometimes you have to change these clips. I will show you the video how to change these clips. And this is the new 3-in-1 tool from the locator company, from the zest.com. So always the gold is the driver. And now the attachment and the attachment of the insertion and the removal end is the same end on that 3-in-1 tool. So this one here, when you remove that, is your insertion tool. And when you place that portion is your removal tool. And see how it's going to be removing some catch up. And then in order to remove it, don't break your fingernails, just have to turn this one. And there's a plunger inside, it will push it out. And then here we're going to use that blue. So by now you know that that denture belongs to a female patient. And it should snap in. If everything is fine, it should snap in. Okay, a small organization thing. If you have any questions, there is a question box on the right side of drop down panel. So you can start asking questions if you have any questions, so we can answer these questions after the end of the session. Badly misplaced implant, sometimes it happens. I don't know what the surgeon is doing here, or perhaps problem with the eyes and the hand coordination, eye-hand coordination. And this is what happened. And you have 4 implants. And this is why I'm a prosthetist. So all these problem cases, they come to my practice. What should we do? Now, certainly you can remove those, but you're going to destroy a lot of bone, because even a misplaced implant will osseointegrate. So we have to do our best to see. So we end up doing a diagnostic denture, and we have to be able to make these locators as parallel as possible, and thanks to the CAD/CAM protocol. And this is through abutment. They have a nice service for you to make your abutments as parallel as possible. So I like them to send me the email of the final design. I have to check it. Once it's checked, I'll go and tell them to mill it. Once it's milled, they will charge you. If they have to redo it, then there's an extra charge for a redo. And this is what you see it on the cast. And it's a 2-piece instead of 1 piece. But it has to be part of that engaging, has to be part of that internal hex of the implant, and you have a separate screw is going to keep that abutment over the implant. And this is the denture. And here, if you're going to pick up these locator clips, you have to do 1 at a time. And even with 2, do it 1 at a time. And I paid my share. How do I know that I have to do it 1 at a time? Because one time I did it both in the same time, and the denture locked in place, and because of that angulation problem, and then I had to destroy the denture to be able to take it out.
Mississippi, 61, 62, 63, 64.
And you can get a nice aesthetics and good function, good fit, and you get you that stability and retention for that patient. So in the end, I want to share this quote by Mother Teresa. Not all of us can do great things, but we can do small things with great love. I thank you for your attention, and I'm ready for questions. So we have one question here. How often do locator attachment need to be replaced? How to reline the denture? Okay, how often? In my practice, I usually see the patients every 6 months. Most of the time, I do not replace the locator in a 6-month period. Usually it takes a year, sometimes 2 years. If you have to replace it as I said, every few months, then there's a problem with the biomechanic of the denture. It's very, once you learn how to do a good balanced occlusion and you find a good technician who can help you get that balanced occlusion, certainly your problem will be much less. Biomechanics, it's always biomechanics. And during that, when you attach the denture, part of the instruction you have to give to the patient is you tell him that clip is the weakest portion of the whole concept, of the prosthesis. So these clips are made to be replaced. And usually I tell him there will be part of maintenance of your denture, and there is a fee. When I want to change that, it's going to be a small fee for the replacement of these clips. It's like you have a car and you have to change the oil from time to time after a certain number of miles. How to reline the denture? Reline the denture is very simple. What you have to do is you remove you remove these housings. Okay, you take a small fissure burr and you remove the housings, and either you can replace them with healing abutment or not. But remember that you have to use, if everything is fine, if the occlusion is correct, and just have studies showing that usually after 3 months, after 3 years, you might have to do a reline because of that alveolar bone shrinkage in the posterior areas. So you remove it and then you do a wash with PVS and adhesive, and certainly you have to make sure that the occlusion is correct. And then when it comes from the lab, the holes, you do it the same way as we did the video how to attach the denture back, how to attach the denture to these abutments. The other question, what is the best treatment option for a mandible that has a V shape and a mandible that have a U shape? One to choose ball attachment and one a bar attachment. Okay. One of the indications for 3 implants is when it is a V shape. A V shape, you can put one at the apex of the V and one implant on each side. If you do a good custom-made dentures, you don't have to have a third implant. But remember, the first choice, if patient has a good bone and good ridge, first choice is to make a fixed bridge, fixed prosthesis. So, and then you can downgrade it according to the time available for the patient for the treatment and also for the money that the patient has. A U shape is the same thing. You know, I know that in some books they make a difference on the number of implant according to the shape of the ridge and so on. As I showed you, if you can control the biomechanic of the denture, if you follow a good occlusion, good flanges, a good technique of fabrication dentures, usually 2 implants suffice. I wrote a chapter in one of the oral surgery book on implant overdenture, and I said there is an indication to place only 1 implant in the middle of in the symphysial area, in the middle of the anterior portion of the mandible. And this is mostly related to elderly patients that are in retirement homes. They don't have a good muscle coordination, facial muscle neuromuscular coordination. 1 implant can help because of their health, because of the money involved and so on. But certainly 1 implant is better than nothing. So 1 implant can be a good indication for these type of patients. V-shape, 3 implant. U-shape, you know, U-shape is very good if you have enough bone and you place more than 2. When to choose a ball attachment and when to do bar attachment. Studies showing if you're doing only 2 implant, you can do either stud by a separate attachment or you can connect them with a bar. When you connect them with a bar, money is a factor, it's gonna costly, but the outcome is gonna be the same as not to connect these implants together. Now, if I have more than 2, if I have 4 and above, and most of the time you have angulation problem, I like to connect them with a bar. When you use a bar, then you have to have, as I said, enough inter-arch space. So these are important things. And then when you connect them with the bar for more than 2 implants, like 4 or 5, then that prosthesis you're going to be making, I usually refer to it when I talk to my patients, I refer to it as a removable bridge. It's going to feel retentive like a fixed bridge, but it's removable by the patient. So hopefully one day I'll come back and we talk about a bar versus fixed bridges. What is the recommended length of implant for 2 implant supported lower denture? What is the recommended length of implant for 2 implant supported lower dentures? Doesn't matter mostly about the length of an implant. We know for a fact if you use a threaded implant with a rough surface, usually 8 millimeter is acceptable, but certainly if you have more bone height, then you can make it up to 10, but 8 is acceptable. Remember, as I said, implant is going to help the biomechanics of your prosthesis. So aesthetics and function and occlusion is very important as much as the length of the implant. What else? Okay, no other questions. Any other questions? Okay. Remember that here they tell me do not forget to fill out the evaluation for the CE certificate. And remember, you will have 1 hour of continuing education. And please don't tell the staff if your spouse is watching, you watch the webinar, you still cannot get 2 hours of CE. You get only 1 hour of CE. Small joke. Okay. Well, have a good dreams. Hopefully you will not have dreams, bad dreams about problem with overdentures.